Back up and be ready to go.
Need to stand at any certain spot or
No,
anything?
no, honestly. Got a recorder, or the microphone, but that doesn't work very well.
Okay.
All right, guys, we're gonna go ahead and get started. I'll introduce Dr. Nicole Farrar. She is effectively in charge of running the medical school. She also helps with our SIM.
It's not wrong. I mean, he's not wrong.
In charge of SIM, clinical education, does all the fun things with the medical students. She is a retired recovering hospitalist, critical care doctor.
Still.
And is going to talk to us about ACLS. Dr. Farrar, thanks.
Morning, everybody. So I didn't know I graduated to running the medical school, but I mean, I guess someday. My husband's asked if I'm the dean yet, so I guess. I don't know where to stand, so you guys can hear me and see and do all the things. So I'll just wander around if that's okay. Everybody okay with that? All right, so as Dr. Chronister mentioned, formerly an intensive care unit hospitalist. So I graduated from our program here in 2009, and I spent a couple years actually as a teaching attending here before I left the nest, as I like to call it. For family reasons and other reasons. Love OSU, please don't get me wrong. So I left the nest and I went over to St. John's, signed on there as a hospitalist, and after a very long story that I can tell you guys another day, I ended up landing in the ICU because they needed some help. Our training here was so awesome that I fit right into the ICU system, and then I never left. So 7 years there as an intensive care unit hospitalist. And I spent a lot of my time running codes and running rapid responses. So I hear you guys still call it the rapid response team here. That's what we called it there. So rapid response codes. I also worked for about 2 years before I left. I also worked with the OU internal medicine residents. So I got to run codes and teach the residents things too. So I've been on all levels of medical education now. I used to be the course director. I was Dr. Cook's role back when I was here the first time for the students. And now, as you mentioned, I'm a big into simulation. So I'm now, I added my new title there. I'm really proud of that. Physician advisor to simulation. That's one of my new titles. So tomorrow morning, for those of you that get to come over to Sim, you get to see me again. So that's a little bit about me and why I'm here and why I have some reason to stand up here and talk to you. I am not a cardiologist. I am not an electrophysiologist. In fact, cardiology, one of my least favorite subjects. So just so everybody knows where I'm coming from, this is not, this is part of my day. This is going to be part of your all's lives for the next few years. So that's why I'm here. Dr. Chronister called it an ACLS refresher, right? So all of my third-year students just took ACLS with us. So they're going to know all the answers, so they don't get to respond during this section. Except I know their names, so that's the only people I could call on today. I'm in education now, so we have to have learning objectives to go along with anything that I do. So we're going to discuss several different things today. I told Dr. Chronister I started this lecture like 5 different times because I couldn't figure out how to put it together to make it all make sense and to be an effective teaching tool. So we're going to jump around a little bit. This is not going to just be about algorithms. I want you to kind of think about the response to an emergency, the algorithms, and then your role as the physician. So we're going to discuss the approach to arrhythmias with a pulse and the pulseless arrest. We're going to talk about what a physician role is during resuscitation. And then I didn't pull your all's attendings because they can chime in. I actually pulled some of my buddies that are all intensivists who actually run codes with residents and got some clinical pearls that they wanted to share with you as far as their experience of what it looks like when they go into a code with a resident. So that's the plan. I've never put a disclosure in a lecture. Dr. Jones always does. I don't know if you peds, Dr. Jones. You guys know Dr. Jones, right? So he always puts those disclosure slides and they crack me up because it always says none. This time I actually do need to disclose something though. So I am an ACLS instructor, certified instructor. So most of the things that we're going to talk about today are obviously related to AHA, American Heart Guidelines for ACLS, right? That's how we base our practice. Other elements of my discussion are going to actually come from practical experience and how we've applied those guidelines to patients. So I will try to differentiate as best I can going through what is AHA and what is Farrarisms. Okay, so we're gonna take a quick poll. How many people in the room have seen a code? Been to a code? Okay, how many people have participated in a code? Chest compressions, meds, you did something. How many people have run a code? You're the team lead. The seniors are in the back, right? Yeah, okay. And Dr. Cook, and Dr. Chronister is the team. Okay, so just so I know, because I don't get to work with you guys every day, of who's done what in these situations. Okay, so here's our warm-up question. Now, I was told this morning by one of your lovely first-year residents that it's okay to still call them interns, right? I didn't want to offend anyone. So, interns, this one's for you. We got to wake up. I got to get somebody like participating. So you're on call overnight in the ICU. The code blue goes off. What's the first thing you're going to do? I even gave you choices. Anybody? Okay, so D is the correct answer for all of my third years that just took boards and they know how to do this, right? So who thought about C though? Don't lie. Who thought about C? Because I'm not kidding. This is a thing, right? Slowly get there. Hopefully somebody else is going to beat me. I don't want to have to be the first one in the room. So obviously the answer is take a deep breath and go deal with the patient, right? That's the answer. That's your training. That's what you're going to get as we go through. Okay, so this is kind of the section of the talk where we talk about preparing to respond. How do I go to an emergency? What do I need to be thinking about, right? So first of all, you can't panic, right? You don't run screaming in the other direction and all of those things we saw on that other slide. You've got this. You have the training and your job is to go and take care of the patient, right? So focus on that and don't panic. I think it's really important to know what your role is as part of your hospital's response team. So some places call it emergency response, rapid response, the code team, like depends on the terminology. So what is your role? When you get up to go respond to that code, do you know what your job will be when you get there, right? Now that's gonna vary, right? You may have different roles. So the third year student is probably not running the code, right? They know that. They're probably getting in line for chest compressions or helping go get supplies. But they know that if they had to, they could run a code, right? They're all ACLS certified. Know your role. I say facility dependent because some facilities, internists don't run the codes. Some places have ER run the code, right? So if you go out moonlighting as a second or third year and you go running to the code and the ER is like, what the heck are you doing here, right? So like know your facility and know who's in charge of what. And then available personnel. So sometimes when you go to a code, not everybody on your normal team gets to come, right? 2 codes happen at once. What do? Right? Who's going where? Who's going to delegate? So you just want to think about like big picture. What is my job when I get to that room? And you're not going to know that for sure, until you guys talk about it. And that's why we're doing this. The other thing that I want to point out on the preparation is please observe all of your PPE precautions. This is outside of COVID. I mean, obviously everybody's got a heightened sense of that. I'm standing here talking to you in a mask. But patients, just because they're dead doesn't mean their C. diff is gone, right? It doesn't mean their MRSA is not real. So protect yourself, protect your other patients. Take the 5 seconds to put your PPE on before you go in the room, right? You can be putting it on as you're going in the room if it's not a respiratory situation. But just remember to observe your precautions. Okay, so I'm going to break these down because I didn't want it to just like fly by. So initial assessment. Okay, this is the Dr. Farrarism part of the talk right here. It is my biggest pet peeve when you walk in the room through an emergency call and no one talks to the patient. All right, now, if the patient is dead and CPR is in progress, don't talk to the patient. Okay, like so I can totally see somebody going there like, well, Dr. Farrar said, everyone stop, I have to address the patient. That's not what I mean. But if you go to an emergency and the patient is awake, they are freaking out, right? The entire world just descended onto their room, and 5 minutes ago they're by themselves, right? So the amount of stress and anxiety on the patient is huge. If they're awake, if they're interactive, please go and talk to them. If they're not talking to you, obviously you still need to be assessing the patient. Don't be running around screaming and yelling directions at people. Just start with the patient. Most of the time, if you're addressing the patient, the rest of your team is getting the stuff, right? That's how it should work in an effective team. So one more time, unless CPR is in progress. Okay, this one is also important for me. Note who is in the room with you. Okay, so when you go to a code, how many of you have been to a code and you're the only person in the room besides the patient? Anybody ever had that experience other than Dr. Connister? He's got some different experience than we do. So the majority of the time you're going to have like people, right? Like I just said, they're descending upon you trying to take care of the situation. So note who's there. Staff, other physicians, right? So say you're going to an emergency on somebody else's patient. Is the physician taking care of that patient standing in the room with you? Who's there from your code team? Like, who do I trust? Who do I know? And then also family is important, right? A huge part of American Heart in terms of their current teachings is they recommend family be in the room if possible during arrest situations. Why? It's a trust issue. So the family watching you resuscitate their loved one is often an act of them understanding that you did everything that you could do. So is there family in the room? Because if there's family in the room, sometimes, well, I'm not necessarily saying it's a good thing, but sometimes your behavior and your patterns and your speech need to change a little bit if you've got someone watching you that's non-medical and not on your team. So that's why I always say, just see who's there. So if you're supposed to be in charge, then take charge, right? The worst codes I have ever been to is when nobody knows who's in charge, right? Half of the difficulty of ACLS and code running and emergency calls in general is somebody has to be in charge. So if that's you, that goes back to know your role. If you're the one in charge, then take charge. And then obviously, as part of taking charge, you're gonna delegate those responsibilities, right? So you see what needs there are, you're gonna talk to whomever needs to take care of that to make sure that you get the job done. And one other point, it's okay to ask people to leave the room. If the room is too crowded, there's too many people. Oftentimes at St. John's, we actually had crowd control in the form of our house supervisor. They always responded to codes and rapids. If there were too many people in the room, you just go say, hey, can you kick these people out? And they would, help you. But if you're in a room and you've got too many people and they don't need to be there, it's okay to ask them to leave. Okay, so let's talk a little bit about that whole initial patient assessment. So if the patient, you go to the patient, first thing I want to know, do they have a pulse and are they breathing, right? Like that's basic assessment 101. So if they don't have a pulse, what do? Start CPR, right? Somebody get on the chest, right? If there is no pulse, just start CPR. And then if you're in charge and you're leading, then you also want to make sure you start the process. Okay, do we have the crash cart? I need to get the monitor on. I need to start thinking about my epi. So you're processing 4 and 5 steps ahead of where you need to be, right? So that's where I think I'm not knocking any other specialties. So please, if I give my ER buddies a hard time or anybody else during this talk, I respect all of them. But I think that's where internal medicine does a really great job of running codes because you're always thinking 5 steps ahead, right? So you need to be getting things ready. So that doesn't mean you run and get the crash cart. That doesn't mean you have to get the epi. That means you delegate people to go do those tasks. So if the patient has a pulse, that's obviously way more complicated, right? So what kind of things do we need to be thinking about? What do I need to be doing patient assessment wise? It's an emergency call, rapid response goes off. I'm going to go in and look at my patient. They have a pulse and they're breathing. So what else do I need to think about? Anybody, I'll just open it up to the room. Since I don't know everybody, I won't call on people. No, nobody? Okay, do I have IV access? Good, right? Because how am I going to give drugs if they do get sick or I need to give them something? Good, what else? Are they protecting their airway? So I need to assess their airway, and along with that, I would just put oxygen in there, right? Like, do I need oxygen? What's that look like too? Okay, what else? Right, so 9 times out of 10, if you go to an emergency call, you almost end up putting them on a monitor anyway, right? I mean, there's very few times that you get there and you're like, oh, this is bogus, right? So probably put them on the monitor. What else do you want to think about? Okay, yeah. So are they interacting with me? So I don't think, Will's not talking about doing like a complete head to toe, right? He's saying, Are they interactive with me? Is this their usual baseline? Like, what's their mental status? What else? Anybody want to know blood pressure? I probably want a blood pressure. So I just put a few things that I think you should think about every time. It's easy when you get there and they don't have a pulse, okay? And I know that sounds really horrible, but they don't have a pulse that's lined out for you, right? Like, we tell you, here's what they say to do. If they have a pulse, it's a way more complicated situation, right? Because you got to do all of your assessment. So are they responsive? Neuro check. Are they in distress or are they not? You got your monitors, your IV, your O2. In our simulation world, we call that the safety net, IV O2 monitor, right? That's how the ER practices, right? They immediately get that going. That doesn't mean you need to give them oxygen. It just means you need to assess their O2. Finger stick blood sugars. I can't tell you how many times this one's burned people over the years, right? So a simple, quick finger stick, even if they're not a diabetic, just check it. That way you know. And then obviously, depending on the patient, there may be something else that you know about the patient that would be helpful. I would say too, in this situation, the assessment is going to vary if you know the patient versus if you don't know the patient, right? It's a lot easier to take care of somebody that you've been taking care of, right? You get called by the nurse or you go to a rapid on your own patient, you have a lot of insight. If it's a new patient to you, you've just got to make do, right? So the assessment may be different depending on your history with the patient. Okay, so I just kind of have the make it simple motto, right? Codes are stressful, rapid responses are stressful, everybody's, heightened, everybody's got enough epi to loan the patient when you get to that code room. So just make it simple. Assess the patient, number one, every single time. You're going to answer the first question. Do they have a pulse or not, right? If there's no pulse, pretty straightforward. We're going to look at that rhythm, start CPR, which you guys told me, and then you're going to follow your ACLS algorithm. I'll clarify really quickly. If you have them on a monitor and you can look at that rhythm before you start CPR, obviously that's appropriate. If they're not on the monitor, don't delay starting your compressions to get them on the monitor, right? So you can assess the rhythm within that first couple of minutes of the code. And then obviously if they have a pulse, we've already talked about, then my next decision tree is, are they stable or unstable? That's the hardest part when we were teaching these guys ACLS because they haven't seen patients yet. So there's a doorway assessment of stable sometimes, right? You guys walked into a doorway and you're like, oh, that patient looks bad, right? So that may be all you need to say, nope, they're very unstable, versus you may need to gather some more of your information. And then if they're stable, all that means is I have time, right? Take your time, assess the patient, try to figure out what's going on. If they're unstable, then can I identify why? Is it cardiac? Is it respiratory? Do I need to go down an ACLS algorithm? Or is it something else? Okay. I'm talking fast, but I want to make sure we have a lot of time at the end for like questions and discussion. Any questions about sort of that thought process on going to see the patient, assessing the patient, responding to the code before I move on into algorithms? And you guys can stop me at any time. I'm not a super formal lecturer in case you haven't figured that out yet. Okay, so we're going to start with the arrhythmias with a pulse. These are the harder ones, right? As we mentioned, the other ones, these have algorithms too, but they involve a lot more thought processing. So let's just list them off real quick. So just these are reminders. So this is ACLS refresher. So I'm just going to assume that you guys haven't run a code in a while. That's how I designed this lecture. So you've got your Brady side and your Tacky side, obviously. These are the AHA listed, rhythms that they want you to know. So if you go to the room and you see, let's say you see a 3rd degree AV block on the monitor, but the patient doesn't have a pulse, what do we call that? PEA, right? So just remember, I don't care what the monitor says, right? I care what the patient's doing. So if they don't have a pulse, all of this goes out the window and I'm going down that pulseless algorithm, right? So the pulse is the key. Never trust the monitor either. Always double check. Okay, so I kind of made my own algorithm, so to speak. The AHA ones are, you guys have seen those, so you can look at that later. This is sort of this one obviously looks pretty similar because bradycardia is a lot more straightforward. So I kind of broke these down. So on the Brady side of it, again, same principle every time. I assess my patient. Are they stable or unstable? So if they're stable, then that's where you talk about supportive care. We got to keep an eye on them, try to figure out what's going on. If this is a new bradycardia, what's happening? Do they need more workup? Do they need more interventions? That's the part where the ACLS ends and the doctoring begins, right? So that's where you all have to start thinking about clinical judgment. Do they need a cardiology consult? Is this somebody that needs a pacemaker? Are they on too much medication? So you've got to start thinking through what might be causing it, or if it's even a problem, right? If they're a marathoner and their heart rate's, 48, that's maybe just fine for them. So you got to make those decisions. If they're unstable, then obviously we have to intervene, right? So unstable, again, by AHA guidelines, hypotension, severe chest pain, altered mental status, signs of shock, that's what they classify. Again, you guys sort of know what an unstable patient looks like. I would argue that the AHA algorithm, so here's the Farrar side again, that you probably actually kind of have 3 categories of bradycardia, in my opinion. You have the stable one, you have the unstable one, and then you have they're about to die unstable. Does that make sense? So I would manage they're almost, they're on the verge of dying unstable slightly differently than I would manage just the run-of-the-mill unstable. But by AHA guidelines, they're going to tell you to give atropine, right? 0.5 milligrams IV as your first line drug for an unstable bradycardia. Now, I don't think it's ever wrong to give atropine because it's usually right there, right? Push the drug, it's not going to hurt anybody. But know already that that's part of the physician role is you got to be thinking, is atropine going to be effective for my patient or should I be doing something else? I always kind of give my own, just clinically and in practice, I give it a 2-dose rule for atropine. So if I give atropine during this situation and it doesn't work, number one, I'll just go ahead and assume that maybe it was an IV issue or the drug didn't get there. I'll go ahead and get the second dose in, but I don't go past 2 doses. If it doesn't work, it's not going to work, right? So if I know what the rhythm is ahead of time, so if it's a 3rd-degree AV block, is atropine going to do anything for you? No. So if you know that, then you don't even have to give atropine, right? They're not going to check you off and say, oh, that doctor didn't give atropine during that situation because you had a clinical rational reason why you didn't. So at that point in time, if you can make that decision early, then you can go to your other options, right? So you have 3. AHA would suggest these are all equivalent. Transcutaneous pacing, dopamine, or epi drips. I went ahead and put the dosing up there. Generally, when I respond to a code, I'm like, can somebody get me an epi drip mix? I don't actually go through all those calculations and things, right? My critical care nurse is going to help me do that. But if you choose dopamine or epi, a lot of times it's a matter of what is there, right? On our crash cart to St. John's, there's a drawer, they've got a bag of mixed dopamine, you just grab it and go. Versus if you had to mix it, versus if you can't get it. Transcutaneous pacing, a lot of people save for the last ditch. I think that that's appropriate if your patient is in that sort of mid-range unstable. You've got time that you're working on things because pacing is uncomfortable, right? Has anybody ever paced a patient transcutaneously? Dr. Cook and Dr. Chronister? Yeah, okay, we got one. So thank you.
Sorry.
Thank you. Did your patient love you when you were pacing? Were they awake enough to know what was going on?
No.
Okay, so if they're not awake and they're literally, that's that brink of I'm about to die, pace away. But if they're awake and they're interactive, and you have to balance that. Now, if it gets worse, pace them. Sometimes pacing is easiest because that's what you have, right? You're already on the monitor, you've got everything ready to go. So it just depends on the situation. Let's see, I think I've beat bradycardia to death. Okay, this is where it gets real complicated, despite my keep it simple methods. So obviously, same thing. This time we're going to the room, we got a tachycardic patient, stable or unstable, and we're gonna go down the tree. Lots of branches to this tree because you've got to be able to look at your complexes. So on the stable side over here, obviously at that point in time, my patient is stable, so I've got a little time, right, to think about it. They're going to become unstable if I don't do something, but I've got a minute to kind of get my bearings. So I'm going to look at their complexes. Is their QRS complex narrow or wide? That's the next branch point. If it's narrow or wide, then I need to know if it's regular or irregular. Usually that will help you compartmentalize what the rhythm is likely, right? Now this isn't like foolproof or anything, but you can see there, if you go to the assessment and the patient has a narrow complex tachycardia that's very regular, I'm thinking it's probably SVT, right? Like generally speaking. If it's irregular, most likely you're thinking AFib, right? So same thing on the wide side. Regular would be VTAC, whether that's monomorphic or polymorphic, doesn't matter. VTAC, you're going to treat that very similarly. And then if it's irregular, generally AHA calls this unknown. Sometimes you'll see it written as bizarre complex tachycardia, right? Nobody knows what the heck the rhythm is. We don't know where it's coming from. There's some activity, but it's not really looking like anything we can identify. So then on the other side of the tree, you've got your unstable patient. So notice, as soon as I label them unstable, my next thought is I've got to prepare to cardiovert them, right? So if I don't get them out of that rhythm and they're already unstable, what's going to happen to them? They're going to die, right? They're going to arrest if I don't hurry, right? So I'm going to prepare for cardioversion. So I'm going to have somebody getting that patient, making sure they're hooked up and ready to go while we're looking at those complexes. We still need to look at the complexes because the complexes help determine what the energy that what energy we're going to use to cardiovert them. So again, same tree at that point in time for unstable and stable. So part of this illustration is to show you that really at the end of the day, it's very simple. You only have a few choices and they end up kind of being the same once you get past the stable or unstable. So remember, stable, time is on your side. So this is where you're going to be thinking meds as first line, non-invasive treatments, because I don't necessarily have to hurry, versus the unstable side, you don't have time. Electricity needs to be your first thought, right? Nobody likes shocking a patient. Does anybody enjoy shocking a patient? I probably shouldn't answer that question. I don't like shocking people, right? When I was here as an attending, there was a cardiology fellow that cardioverted a patient on the floor, awake, patient totally fine, and didn't give him any sedation. That patient never, well, there's a lot of words that came flying out of that room on 5 West, but just know that like electricity is not always the go-to, but in this case, you need to. So then this is kind of the treatment side of those tachycardias. So again, we're gonna look at the half of the tree that was stable. Down the narrow side of it, if it's regular, we talked about SVT. So I put the treatments there in the orange boxes. These are the AHA guideline treatments. So vagal maneuvers, adenosine, 6 and 12. Has anyone ever pushed adenosine in the room? Okay. So what happens, what do you need to be telling the patient when you push adenosine if they're awake? And again, we're stable, patient's stable, they're awake and they're talking to you. What do you need to tell them? You are not going to like this. I like that you'll feel like crap. That's excellent. So why? What makes them feel like crap? What is it doing? What is adenosine doing? Right. So we're going to stop their heart basically, right? Nausea, chest pain, shortness of breath. I've never had it done to me, but if you talk to people after it's over, they feel pretty crappy, right? So again, it's back to that principle number 1. This is a patient you're treating, so you need to talk to your patient. So vagal maneuvers, adenosine 6 and 12. By the way, I have never seen 6 milligrams of adenosine work. Never. I've always had to push 12. I mean, I don't know. Sometimes I just give them 12 up front. That's a non-AHA-ism. That's a Farrar thing. Okay, so we talk about vagal and adenosine on that SVT side. How about the AFib side? So again, stable, narrow complex, but it's irregular. Everyone in here knows how to manage AFib, right? You guys do this in your sleep. So beta blockers, calcium channel blockers, patient dependent. We're not going to dwell on that because that's one of your wheelhouses probably already. So on the wide side, if it's regular, Again, we're talking VTAC. So monomorphic VTAC, polymorphic VTAC. If it's polymorphic VTAC, what are you probably choosing first? MAG, right? So polymorphic VTAC, AKA torsades, right? So if it's polymorphic, I'm probably going to give the MAG first. Have I ever given amiodarone or an antiarrhythmic for polymorphic? Sure, but MAG usually would be number one. So I put them both in there. AHA does not have magnesium in the algorithms, just again, so everybody's aware. How much MAG do you give? Well, how much do you have on the crash cart, right? Some people have a gram, sometimes it's 2 grams, like whatever you have, give it. And if you need more, give more. And then remember in amiodarone, if you're going to be using that, which is the other general AHA recommended antiarrhythmic, 150 milligram bolus followed by a drip if the patient is stable, right? We're not in the pulseless algorithms. So we're going to give amiodarone. Remember, it's a class 3 antiarrhythmic. There are other choices that AHA lists in their algorithms: procainamide, sotalol, lidocaine. What do you guys use here for a wide complex? What's your drug of choice? Anybody know? I don't know, I'm asking.
Well, I mean,
You guys use lidocaine? Okay.
If they're refractory to amiodarone, then we'll do
Okay, if they're refractory. So that was our practice too. So amio was usually first, and then you kind of go from there. I don't like giving drugs that I've never used before, right? So procainamide and sotalol, generally where I practice, and certainly in training here, we didn't use those drugs. Electrophysiology and cardiology use those drugs. I don't feel comfortable with them, so I don't use them. And there's another principle that you kind of remember when you're talking about using antiarrhythmics. The antiarrhythmic that broke the rhythm is usually the one you want to continue, right? So that's another huge factor in choosing an antiarrhythmic on the physician side of thinking about ACLS. Because I can give amiodarone as a bolus and drip them, and if it works, great, and I move on with life. The side effect profile is slightly different than our other antiarrhythmics. The other antiarrhythmics have a much higher incidence of QT prolongation, right? So I just made things worse potentially by trying to treat them. And I think lidocaine, I've seen a lot of people on lidocaine drips to take care of a fair amount of people in the cardiac ICU. Lidocaine drips have a lot of side effects, like just the symptoms, right? Vision changes, nausea, vomiting. These people get dizzy and they hallucinate, especially if you have them on a really high dose. So lidocaine just sort of practically was not always the best choice. Now, if they needed a second drug, lidocaine was the go-to though. So it just depends on your patient, depends on your comfort level.
And here what we tend to do with lidocaine is once the arrhythmia is corrected,
Wean it off. That's exactly what we did too. So lidocaine is your second agent. You stabilize them and then you leave them on the amiodarone, typically. Okay, so then on the wide side of the irregular stable patient, again, this is that weird unknown. We can't really identify it. It's not labeled as anything. That's another situation where you're probably going to consider your antiarrhythmics. The other thing, I put cardioversion with a little question mark. These people may need to be cardioverted sooner rather than later, even though they're on the stable algorithm. These people don't stay stable for long, so you may end up having to go ahead and get electricity going. Okay, so that's the stable side. We'll walk down the unstable side to review. So narrow and regular, back to our SVT conversation. If I need to cardiovert someone in SVT, so I put the joules down here. These are the AHA recommendations. My thought process is if you just kind of can't remember or nobody's got the cards or nobody, right, think 100. Just 100 is easy, right? You can always do more. 100 is a nice round number for most of these. So SVT, the recommendation is 50 to 100 joules. And remember, you need to consider sedation. Not every patient should be sedated for cardioversion if they're unstable, right? That's the clinical judgment side again. So if their pressure's crap and they're unresponsive, but they still have a pulse, I'm probably just gonna cardioversion them, right? If they're awake and talking and you see they're deteriorating and you know you need to cardiovert them, but you have a minute, you might give them something, okay? What are our options to give if you do want to sedate a patient? in this situation? Anybody? All right, come on, seniors. Propofol, okay. So propofol is not a bad, oh, never mind, that doesn't count. No, I'm just kidding. Propofol, yes, not necessarily a bad choice. What's the danger of using propofol? Right. So I just dropped their pressure and I didn't have one to start with, right? So propofol almost universally is going to drop blood pressure. I don't care how much you give them or how little you give them, their pressure is going down, okay? So what about maybe a more blood pressure? Ketamine, right? So I didn't practice with ketamine. We didn't use ketamine when I was a resident. I didn't have a lot of interactions with it at St. John's, but it is going to be the go-to drug now for most places. So ketamine, are you guys using it here? Yeah, get familiar with ketamine because I bet that's what you're going to see, especially as you guys enter practice world. Etomidate's another choice, right? That's probably the one that I have the most experience with. Versed, also an option, right? Versed is probably what we used when I was a resident all the time, mostly Versed. We didn't have really access to Etomidate, so Versed is what we gave. Versed is still going to make them a little hypotensive, but at the end of the day, if you need to give them something and Versed or propofol is all you have, do it, cardiovert them, and then hope that their pressure responds to a cardioversion. And if it doesn't, support their blood pressure, right? Like it's not like it's the end of the world if you don't. Okay, we're gonna come back to the AFib one last. Let's go over to the wide side. So regular VTAC, monomorphic or polymorphic, whatever it is, it doesn't matter. If you need to cardiovert them, 100 joules is the recommendation for the starting dose. And then if it's that weird, bizarre, irregular thing that you can't recognize, that's probably a time to consider defibrillation because they're not going to have a pulse for long. So at that point in time, it's probably better to just defibrillate. And remember, synchronized cardioversion, every time if we're going to cardiovert someone, if we're going to shock someone with a pulse, you need to deliver it in sync with the R wave. So you hit the sync button, right? It matches up. Has everybody seen that on the monitors? Sync button, it matches up. A couple things about the AFib. I feel like in my practice, it was not a very common occurrence to cardiovert the unstable AFib patient. I don't know if Dr. Cook or Dr. Chronister want to weigh in or debate any of that. Why? Because there's a lot of other factors that go into that AFib patient that you probably want to think about before you're going to cardiovert them. Now, if the patient is unstable and they are in AFib with RVR, and they're about to die in front of you, you will never be faulted for cardioverting them, right? Like that is standard of care, that's AHA. But sometimes I think it depends on the patient. If you know the patient and you know they have a history and they've been in AFib for 20 years, what do I just introduce? I introduce risk of stroke and all of those things. Are they on anticoagulants? Are they not? This is where the doctor thinking has to come in. Again, the risk of, if I cause a stroke, but I save their life, right? Like, so we're kind of in that life and limb versus functionality thing. So again, you're not going to be faulted, but I think just stop a second before you cardiovert that patient. Do they have an underlying cause of something? So let's say your patient who has a chronic AFib, who's here with sepsis, right? And they're tachycardic and they're hypotensive and they're getting worse from their sepsis. If I treat the underlying cause, their AFib with RVR is probably going to get better, right? So I think the AFib part of this tree is a lot more complicated than what the AHA is going to suggest. So again, you still can go down that road. You can still cardiovert them. You're not wrong. But the success of cardioversion in AFib is much, much lower than all of those other ones. So just things to keep in mind. And remember that part of the ACLS algorithm that all of my now third-year students loved is expert consultation. They all wanted to call in the expert consultation. Sometimes you're the expert. That's where the problem lies, right? Now, are you still maybe going to need your cardiologist? You know, at St. John's, I had access to electrophysiology, which was wonderful because those guys are amazing. So it depends on what's going on with the patient. Okay. The fastest review of all of those I've ever seen. Okay, so let's talk about the pulseless side real quick. Again, this is the easier side for most people. High quality CPR, don't forget, this is the cornerstone of all pulseless arrest, right? If you're not doing CPR, you're not helping the patient, right? So above all else, high quality CPR. So I have your reminders there, 100 to 120, 2 to 2.5 inches. Make sure you allow for chest recoil, right? All the way up, let the coronaries fill. Remember, we're gonna deliver breaths in a 30-to-2 ratio. This is probably the most common thing done incorrectly in the hospital setting in ACLS that I see. I don't know if anybody else has noticed this. People don't want to do 30-to-2 and they say, but I'm in the hospital. I don't care. Does the physiology of the patient change because you're in the building versus on the sidewalk? No. If you're delivering breaths outside of an advanced airway, they need to be stopping those compressions to deliver the breaths. Why? If you're trying to compress and you're trying to squeeze air in that bag, you're fighting with yourself and you're not delivering effective oxygen to the patient. So unless you intubate them or I-gel them, right, don't stop doing the 30-to-2. You will see this. I've had to argue with people in the code before about this. So just stand your ground. Again, you're going to get your monitors, you're going to get your access. In-tidal CO2 monitoring would be the benefit of the advanced airway. I don't have time to go into when you intubate and when you don't on all of this because I want to make sure we get finished. We can do that another day. So in-tidal CO2 monitoring would be the benefit of an advanced airway, but you need to use your clinical judgment on whether or not it's appropriate to intubate that particular patient. We do not need to intubate every single arrest patient. Okay, so when I was training, Dr. Cook and I were training, we intubated them all, right? We didn't ever distinguish. I don't know if Dr. Comster had the same experience when he was training. We're all in about the same training age. So we used to intubate them all and ask questions later. So instead, I would encourage you to ask questions early and make that decision on whether or not that you should intubate. So here's the only official AHA algorithm I actually put in the lecture, just because this is the one that you need to know. You're going to start your CPR, right? Then you've got to assess shockable or not shockable, right? So it's the same principles. If it's shockable, what am I going to do? I'm going to prepare to defibrillate, right? I'm doing high quality CPR and I'm going to get ready to defibrillate. After defibrillation, your drugs are going to be epi and then your amiodarone. And remember, in pulseless VTAC or VFib, you use a 300 bolus, right? It's the higher dose. So 300 bolus of amio, and then you continue down your tree. If it's shockable at your pulse check, then we're going to go down and shock them again, right? You just cycle. If it's no longer a shockable rhythm, switch over to your PEA asystole algorithm. That's just high quality CPR and epi, right? Over and over. So again, if there's no pulse at your pulse check, continue down either pathway. If you have ROSC, then you go ahead and start your post-arrest care. So what do I need to worry about when I get to ROSC? What's their blood pressure? Do I need certain labs? Do I need additional imaging? Is there something else I need to be doing for the patient? And then the consideration, every time AHA guidelines, consideration of targeted temperature management, right? Therapeutic hypothermia. Are you guys doing hypothermia much? Yeah, so I think that's probably the hardest question when I was practicing to answer, is whether or not I'm going to cool a patient. There's a lot of factors that go into it, and again, that's outside this talk, but the consideration should be there every time, no matter what, right? You have to think about it at least. So then on the potential underlying causes, remember your H's and T's. So this is where during ACLS training with these guys, it was, oh yeah, we got to think about H's and T's, right? And then they got their little check mark and they moved on and passed their ACLS training. But this is where the doctor stuff comes in, right? You actually have to think about this. You've got to make decisions and decide if you're going to treat any of these items. I'm not going to go into detail so we can keep going. Okay, so I'm going to talk a little bit about the physician role. So remember, I don't want to say you're not special, everyone's special, but anybody that's ACLS certified can run a code, right? It's not, well, I'm the doctor, I have to run the code. That's not the case. But why do physicians usually take the lead, right? Experience and training, obviously in the room, you are likely the highest level trained person. You have training in critical assessment skills, right? So your job is to think through the process and figure it out. Decision-making outside of guidelines and algorithms. So as I mentioned, the AHA gives you guidelines. If somebody doesn't have the training to be able to think outside of those guidelines, then they shouldn't be, but you guys do. So you need to be thinking that there may be some things that fall outside of those algorithms. Obviously, treating the reversible causes requires an understanding of how to treat them, right? Somebody can identify hyperkalemia, but if they don't know how to manage it, it doesn't matter, right? You are the person that's going to help manage that. And then I think this is my favorite, management when the event is over, right? Okay, so if you get ROSC, it's your job to figure out what to do next. No one else in the room is going to do that, right? You have to take care of the patient. And then if the patient doesn't survive, discussions with the family and that team debriefing. I don't know if you guys are practicing regular post-arrest debriefings here. We were not doing that at St. John's, and that was a huge mistake. They started implementing that kind of as I was leaving. So post-arrest team debriefing. Not necessarily, hey, you screwed up. Hey, you didn't use the right joules on that, shock. More about how is everybody's mental health? How does everybody feel? The effectiveness of the actual code running. So remember, good leadership becomes even more important during the crisis. So staying calm is huge. The worst codes that I ever go to are the ones where people are running around and screaming. Like just back off a little bit, take a deep breath and stay calm. I would say be direct. So you don't have to be rude to people because you're running a code. I think there's a weird thing that happens a lot of times when you get into this stressor situation. Be direct and give people the information that they need, but you don't have to be mean to them, right? You're not yelling at them and telling them what to do in that manner. Delegate your responsibilities, which we've talked about several times. You need to make sure you take charge so that everything is being done appropriately. From the leader perspective, when I do a code, it's my opinion, again, this is not AHA, it's my opinion that the leader of the code should not be actually performing tasks. That's my take on it. If you have enough people in the room, they should be doing it, and your job is to focus. Your job is to focus on what happened to my patient, and is everybody doing their job correctly, right? You can't be distracted by, you're up there at the head of the bed intubating and trying to run a code from the head of the bed. I have partners that do it that way. They drove me insane, and I hated working codes with them. So you just think about the ability to multitask, and it is not really effective, especially in this situation. You have to have effective communication. I think everybody's probably knows well about closed loop communication. Make sure that everybody has closed the loop to ensure that the task is completed. Be part of the team. So remember, most of the time, you're not running a code by yourself, right? You may be the leader of the code, but the team is all working with you. The goal is the best interest of the patient. So your opinion and someone else's opinion, if their suggestion is good, take it. Don't worry about pride. For those of you that have seen a code or run a code, what do you have a sense of what's a good code and a bad code, right? If you see enough of them or you go to enough of them, you're going to understand the difference. And I'm not talking about the outcome for the patient. I'm talking about, did we run that effectively, and was that a good team effort? So you'll see the difference. Okay, so I'm running out of time. This is the last thing I have. So again, I didn't poll any of your attendings. They are going to chime in, I'm sure. This is a set of things. I didn't quote them. I paraphrased some of them because some of them were a little bit inappropriate for probably this audience. But so number one, when responding to a code, the patient is dead. You can't hurt them, okay? Roost used to say this. I'm sure Dr. Cook remembers that. Roost used to say this all the time. For those of you that know Dr. Roost, patient's dead. Go do your best, okay? You're not gonna make them worse. If you're the leader, take control and delegate, which we've gone over several times. This one was a good one that I hadn't thought of. So start compressions and give epi. You buy yourself 2 minutes to think, right? This is one of my buddies. It made me laugh. Some of these were hilarious when I'm getting the text messages back. So give yourself that 2 minutes. You know to give epi and start compressions. Everybody can do that, right? All right. If you don't have IV access, I owe them immediately. I think this is something that has, back in the day, if we couldn't get an IV when Dr. Cook and I were training, we're putting in central lines during a code, right? Not effective, right? An IO, you can drill that within a minute of opening the case, right? Central lines, even the best central line person during a code is still going to be a 5+ minute process. So if you don't have an IV, use your IO. I understand you guys are maybe going to need some training on IOs at some point. We can do that in the simulation lab. There's my plug. Okay. One thing that I noticed all of the time when working with residents, the pulse and the rhythm check needs to happen together. And you're like, well, duh, but do you know how many times somebody resumed CPR and you didn't check that rhythm? I have no idea what algorithm I'm on if I didn't check the rhythm, right? So pulse and rhythm check, same time. And remember, that's a 10-second, no more than 10 seconds off the chest. So you've got to have a coordinated effort, which is why your leader needs to be paying attention. Number 6, if you have ROSC, don't drop the mic, right? You're not done. This is a huge thing that we see all the time. You get ROSC and everybody's like, yay, and they walk out of the room. Well, no, so you still have the patient to tend to. Do I need fluids? Do I need pressors? What's happened to them? Do I need to call somebody? You can't just stop when you get a pulse back. I already mentioned the bradycardia thing and atropine. Number 8, again, one of my pet peeves. Don't forget, we're treating a human being, right? This is personal. I understand that you're doing a job, and I understand that if the patient has arrested, then you're going to do what you have to do. But when you're finished running a code, obviously if they survive, it's slightly different because you're working on still getting things done. If they don't survive, stay there, help your nurses, clean up after yourself, take care of the body, right? Because you're going to go out and talk to that family, or perhaps the family's there watching, right? You need to remember that we're dealing with human beings, even though it can be a very disconnected situation. And my final one on this is you always should have a little anxiety when you're headed to a code or a rapid. I still do 13 years later, or however long I've been doing this. You should always still have a little anxiety. Overconfidence is dangerous to the patient, right? You should always have that little bit of like, oh, okay, that deep breath and go on with your day. I still get anxious responding to a code every single time. I'm less anxious about codes than I am rapids. Rapids scare me way more. Code is lined out for me in this nice little algorithm. Rapids, you got to actually really focus and think. And I think along with that is have a healthy understanding of your strengths and weaknesses. Everybody has their good things, the things they're good at, and they have things that they're not so good at. Recognize it and acknowledge it, and use the people around you that are good at those things. If you're not very good at airway, then let someone who is get the airway. Don't be prideful when it comes to patient care. Okay, that's it. Some reason my references slide got cut off, so I apologize. The references are pretty much AHA and all of my buddies that contributed to that. So I don't know if Dr. Cook or Dr. Chronister have any additional pearls to add.
Those pearls are good. I think the key with the code is just chill out and talk, right? Like number 3 is perfect because legitimately, when chest compressions are happening, that's when you get to just kind of like just breathe and you get to start thinking about, okay, what's next? And then you're telling your person on the airway, hey, we're going to do this. You're telling your pharmacist, hey, will you go ahead and start drawing up X, Y, or Z? Hey, what's our time? What are we going to be doing after this? Get your card out. Don't feel like you've got to have a card. Get your ACLS card out. My H's and T's. What am I thinking about, right? So yeah, just chill, breathe. You know what to do. Buy yourself time with your 2 minutes and think about what's next and tell people, okay, once we do the pulse check, this is what we're going to be thinking about. And you can run super smooth after that. I don't know if those of you who are just now starting to run codes or have done them recently, if you've had any issues, successes, things that you guys want to pass on.
Sometimes, like people yelling, sometimes when someone yelling, it can be disruptive. And I guess if there's more than one senior there, that can also be an issue too. Determining, like, because they'll look at the third year and be like, hey, you're running this. But the third year wants the second year to run it to get experience. So sometimes you gotta just tell everybody, quiet, this is my show.
Yeah, I mean, it's true. Like, I've only ever raised my voice twice. So I'm a very calm, like I don't get worked up about stuff very easily. I've raised my voice twice in a code. And I mean, that's over 10 plus years of running codes. But sometimes you have to because nobody's listening. And the whole like residency hierarchy thing, that is hard here. I think it's hard here. If the nursing culture here is anything like it was when I was training, they very much, and this has nothing to do with interns, you just started, right? You don't know as much as a third year. If you do, you have a problem. But the nurses, especially the ICU nurses, go to that senior, right? They're gonna go. So like you said, you just have to say, okay, no, so-and-so is gonna take care of this today. I'm right here helping them. Just reassure them. That's what they need, I think, is a reassurance.
I think I see a lot of times when everything's a big cluster, everyone's good at what they're doing. And so you'll have nurses or staff, they'll start talking to their own colleagues about what their job is. And you have to cut that out pretty fast. And like every communication comes through the team lead. We're not talking over here, we're not talking over here. Make sure that everyone's running their stuff through you, not doing it in parallel to you.
Right. And I think that's probably, honestly, for me, the hardest part of running a code is about that. Like, okay, tone it down over here in the corner, and the sidebars have to be, they have to be to a minimum. And also delegate somebody if you have the resources to deal with the family. So if the family's in the room, give them a person that's their person with them. If they're outside of the room, nominate a person that's going to go and update them periodically. You as the physician can't be doing that if you're running the code. Now you're going to go talk to them after, but delegate the person. We had what we called family care specialists on our units, which was the best thing I've ever seen in my life. They would handle that stuff for us. So delegate, just again, it's all about delegating.
And probably check, first thing you do, honestly, because we're doctors, we like to fix things, make sure they're not DNR. Like, right?
Yeah, oh, thank you. I needed, that was number 10 actually.
Yeah, like go in the room. Hey, what's the code status? Are we doing the right thing?
Yeah.
I've definitely coded DNRs before.
I have to.
Yeah.
Even the ones that have the bright purple bracelet right there on their
That's
wrist.
always right.
Done it.
I have a quick question.
Yes, go ahead.
For pulseless, when we were looking at the white complex regular, amio 300 bolus. With pulse, we did not do a 300 bolus for amio.
Right, so if they have a pulse, it's 150. Yeah, that's where the dose, that's
And
the
then
dose is.
300 and then 150 for the pulse. Okay.
If you're in the middle of a code and you realize there's DNR, you just stop what you're doing.
Usually, yes.
Okay.
So family runs in and like holding up a piece of paper and there's their DNR nice in front of you. No one knew it in the hospital. Generally, you would stop. Or you're coding the patient, you look down and you see that bracelet, then yes, you say, hold on everybody. Like, so yeah, you just stop it.
Or you'll have it a lot of times where someone is familiar with the case, knew that was the discussion, but it wasn't documented.
Yep.
And so then you're telling, hey, get on the phone with their family, confirm that this is a DNR. And then you're still doing it until you get the confirmation.
Yep. If you don't have it fully clarified, I would say you have to err on the side of caution and continue. But if it's clarified and it's right there in front of you, then you stop. Okay, what else?
So the one thing I'll add, and I said this yesterday, so I want to say it again, don't push drugs when you're not doing, you gotta be doing chest compressions with drugs. So that's part of my daily control. And then the second thing is, if you put in the patient a long time, everyone's in that room is working hard. I always ask, is anybody else?
Yes.
have ideas?
Yes, that's a good one.
Is there anything else you guys think we should do?
Yep.
Is everybody okay? Anybody feel okay?
Just think about from a, like if you're at one perspective, when do you guys normally call codes? How long do you normally let it go? It's all
So,
different, right?
yeah, it's so,
Depends on the situation, honestly.
yeah.
And how sick the person is and what, how old they, I'm just telling you guys, I coded a 42-year-old that I discharged on Sunday morning and came back Sunday afternoon with a we coded her for an hour and 15 minutes.
Yeah.
We coded her a long time.
Yeah.
She got 2 kids twice, it just depends on the situation, and then there's some patients, 15 minutes that are situations, I think,
No, I would agree. I think from a guideline perspective, if you talk on the AHA side, I believe the rule is 20 minutes of asystole or something along those lines. But I'm going to tell you, there are very few times that that actually is what we do in real practice. Like Dr. Cook said, I coded a 28-year-old for an hour and a half. I know that that was not right. Like I know that. But sometimes it's a level of comfort that everybody in the room has to feel that you did what you needed to do. So it's really variable. And sometimes it's a situation where you're resuscitating the 92-year-old and all of their kids come in and start watching what you're doing and they're like, oh my God, like stop. And most of the time, I don't worry about the legality, you know, kind of like Ashley was asking about like the DNR. A lot of times it's a feel, right? Like you either have a relationship or some sort of rapport with them, or even if you don't, if a family member came in the room and said, I want to stop, but there's nothing legal documented, that's usually when I will turn the code over to someone else and step out and talk to the family. So that is the one time where I redelegate that responsibility. So I think it depends. What's your experience, Dr. Conister? You have a number?
I think if you're doing it, 20 minutes is right. Like I think
Right.
anything under that, I kind of feel like you didn't give them your best
Yeah.
shot. Anything over that, honestly, I don't think you're gonna have a good outcome. You may get Ross, but you're not gonna
Yes.
get a person back.
Right.
Well, I want to disagree with that because we still got home. 42 minutes, 32 minutes. So we went home.
I feel like Dr. Cook wants to throw down. I don't know what's happening back there.
But I'm just saying that it's true. I mean, listen, most people don't, like the percentage of a person with cardiac arrest outside of the
Yeah.
hospital, the likelihood of survival is what, you know, less than that.
Yes.
I think it's like 2 to 5%, okay? And then in the hospital, the code in the hospital, what's the likelihood of survival? Than leaving the actual hospital. And they may survive that first code, but I'm talking about leaving the hospital and survival. It's pretty low, right?
Yeah, it's around 20 in the
Yeah.
in hospital, and that is nothing to do with neurologic status. That is simply you have a pulse. The neurologic data I think is around, I want to say it's like 12 to 15% leave with some level of functional neurologic. Now, that doesn't mean they're back to baseline. The baseline neuro stuff is in that lower 10, 12%. I didn't look at the most recent numbers before doing this, but that's the last stuff I have. Neurologic recovery is a huge part of the conversation. And therapeutic hypothermia, or targeted temperature management, sorry, I always call it hypothermia. That's another huge thing when you're talking to that family. And the number of people, the number of times that I spend hours with families trying to make them understand, because my night partners put them on hypothermia and they said, yep, 24 hours and we're going to wake them up. That is not how we need to talk about that with our families. Like, please be very detailed and very upfront about how that process goes.
And the other thing I've seen guys with hypothermia protocol is I recommend that you read more of the patient half times slower, like 2 times longer than what our protocol suggests, because I've seen a lot of cerebral edema and herniation and stuff like that when you read more of the patient. And that's not any, that's just cookies on the water you want to talk in class.
And never trust an EEG during hypothermia. Hopefully everyone's learned that. Taylor.
Can you give us a short explanation of that process in case us, the medical students, gets left back at the room and everyone else
Yeah,
is gone
so
and the family's like, what is going on?
The general principle is obviously neurologic protection, right? So you're going to cool them down to, it depends on your facility, 32 to 33 degrees is going to be the general. So generally you will cool them with whatever means. Some places use cooling catheters, which is a big central line that you put in and you actually run cold fluids through it versus it being like an external device. So you're going to cool them, you're going to get them down to that temperature. You're going to keep them there for 24 hours. And then at that point in time, then you start to rewarm them. So like Dr. Cook said, there's a lot of controversy about the timing of rewarming. Most places allow the patient to go up by X degrees in so many hours. So they're gonna rewarm them. And then after rewarming is complete, then that's when you can sort of start reassessing the patient. Neurologic status and all those things. Unless you sedated them for hypothermia. Then your timeline of reassessing their neurologic status has to be pushed way out. That's another controversial conversation that was going on when I left St. John's, is whether or not we need to be sedating and giving all of those people drugs to cool them. So it depends on what you use and how long they've been on it. So you've got to allow that. And, you know, then it gets into all of then we're going to just reassess them. As long as you're giving them an appropriate timeline, that's where I think the danger comes. People here, we're going to cool them for 24 hours, and then magically they're going to be your dad again. You know, that's where people hear it wrong. So I think as long as you're realistic with the timeline, that's the key.
There's a sheet paper in the ICU that gives no criteria for people who should be in the hypothermic protocol, so like take a look at. I always have to look at it.
Yeah. I reviewed the hypothermia indications probably every week. And I mean, I know that sounds stupid. Like, well, you do this every day. Why didn't you know? There's a lot of nuance to targeted temperature management stuff. So I think there's always good to know what your facility does and what they recommend, because that's got research and literature behind them. So I would always use that.
So the first patient's awake and responding to you.
Don't do it. Sorry, I just have this image of like, nope, sorry, you're getting cold today. All right, anything else I can answer? Sorry, I went a little over. Oh, you good?
Thank you very much.
Okay, thank you guys. All right, is that okay? Does that work?